All right. Well, we'll go ahead and get started with this week's sports ultrasound case series presentation. I have the pleasure of introducing Dr. James Wilcox. He's originally from Indianapolis, Indiana, and completed a sports medicine fellowship at Western Michigan University in 2018. He then served as the medical director for various events and specialized in point of care ultrasound education at the Indiana University of School of Medicine before recently moving to Abu Dhabi in the United Arab Emirates. And currently, he directs the ProMotion Sports Medicine Department at Specialized Rehabilitation Hospital in Abu Dhabi. And today, he's going to be giving us a presentation on Olecranon Bursitis.
All right. So thank you very much for having me to come and share a little bit of my interest and passion on musculoskeletal ultrasound with the community. I'm going to go through an interesting case that I have, but using it to kind of highlight how to do a posterior protocol for elbow ultrasound. So a couple disclosures, already mentioned director for the ProMotion Sports Medicine Clinic at Specialized Rehabilitation Hospital in Abu Dhabi. I was the assistant point of care ultrasound director for Indiana University for the last 4 years. I'm an adjunct professor because I'm not there in person anymore, but still keep up ties with Indiana University, and I'm a lecturer for Global Ultrasound Institute as well. So again, the objectives, what we're going to do today is go over the diagnostic protocol for a posterior elbow ultrasound. The AMSSM has a lot of really wonderfully thought out protocols, and so we'll discuss that. We'll go through the images for our case and then talk about pertinent ultrasound anatomy as we go. And we'll also do the ultrasound report. So I'm going to give just little chunks as we go along for each of the sections that we do. And then at the end, we'll kind of put the whole report together. All right, so here's our case. This gentleman came in to the emergency room. This was actually a couple of years ago. He had severe pain, swelling, and warmth over the posterior aspect of his elbow. He noticed it over the course of about 3 days, and he had a fever coming into the emergency room. Of note, he did have a previous olecranon fracture 8 years prior that was managed with ORAF, and but that healed, and he's not had any recent trauma. You can see his vitals there. He did have a measured fever in the emergency room. And so this is his physical exam. They actually did a pretty well documented physical exam in the emergency room. He had marked swelling, erythema over the olecranon bursa. There's some fluctuance, a tender mass that was about 4 or 5 centimeters in diameter, warmth, tenderness over the area, no crepitus, skin was tense. He had a little bit of limited range of motion, both active and passive range of motion. Neurologically, everything was intact. Strength was a little bit reduced with elbow extension, but mostly due to the pain. In the ER, they gave him IV antibiotics for a couple of days for a suspected septic bursitis. They did go ahead and drain the bursa because he was still febrile, and there was some purulent fluid. Came back for Staphylococcus aureus, sensitive to clindamycin, so they had him finish a 10-day course on discharge. And so now you're thinking, well, wait a minute, wasn't that the case we're going to talk about? Well, let me show you the pictures, and then we'll kind of dive into what's going on with this patient. So here's his lateral elbow X-ray, just to showcase the hardware that he has in his elbow. And you can tell in the soft tissue that there's definitely some swelling there in the bursa. Here's a couple of CT scan slices, sagittal slices, and again, kind of showing his hardware. And then you can see a little bit better the bursa fluid here on the olecranon. I highlighted it there for you. So can see it on CT scan, but especially in patients where there's hardware, things like CT scan, MRI, you can get a lot of artifact, especially if the hardware is really close by the structure that you're wanting to look at. So ultrasound can be really helpful, especially in those instances. So he finished his course of clindamycin, and he actually came to see me in the clinic 3 weeks later for a follow-up from the emergency room. He'd finished his 10 days of antibiotic. The swelling was better. The pain was improved. Fever was gone, but he still had persistent posterior elbow pain, and he wanted to get his elbow evaluated. So vitals here, everything's back to normal. Temperature is normal. On exam in the clinic, he had a little bit of swelling over the olecranon, but no erythema, no warmth. Had some tenderness of the triceps tendon insertion. No purulence. The incision had healed. He had a little bit of restricted extension, about 10 degrees, some discomfort at that end of extension. Strength was a little bit diminished too with elbow extension, mostly due to pain. Normal sensation in the hand, the wrist, and triceps tendon stress test. He had some pain on the olecranon insertion. So, like I said, AMSSM has developed these really great ultrasound protocols for every joint of the body. Here's the recommended protocol for the posterior elbow. You want to look at the olecranon process and the bursa. Look at the triceps tendon and the posterior joint recess. It's also important to take a quick overview of the distal humerus cortex. And as you're looking at these different structures, if there's anything, any concern, any tenderness with sonopalpation, you want to use Doppler to evaluate if there's any inflammation. Power Doppler is really good at getting that small, slow flow inflammation from tenosynovitis or neovascularization. And then use dynamic evaluations as indicated. So if there's any concern for ulnar nerve subluxation or snapping triceps, you'd want to evaluate the posterior medial side of the elbow in flexion and extension. And then if there's any numbness or radicular pain, you can also evaluate the radial nerve as well. So I thought this was interesting. The rheumatologists did a Delphi study a couple years ago looking at what's important in an elbow protocol for rheumatology. And they had level one or final tier level one agreement for posterior, longitudinal, and transverse. So looking at a lot of the same structures, and then kind of a second tier agreement on looking on the bursa, the posterior medial space as well. So rheumatologists are also on board looking at the posterior elbow. And then this paper was really interesting, looking at dynamic evaluation of the elbow. And so in particular, highlighting dynamic evaluation of the elbow joint, the posterior elbow joint. Was really helpful at trying to solicit some of those really small joint effusions. So if you can extend the elbow, it relaxes some of the tension on the elbow capsule. And so doing that dynamically back and forth can help some of the fluid maybe come out into the posterior space that you would not have ordinarily been able to see, or maybe get a foreign body to be able to dislodge and you can see it better. So really well done paper by our PM and our colleagues looking at dynamic scanning of the elbow. All right, so patient positioning. So I like to have the patient's arm kind of resting on their stomach. So their elbow is going to be in partial flexion. This is here at 90 degrees. You want it a little bit more extended than that. But I have it on the stomach because then you can have them pull their elbow back if you want to look at the medial side of the elbow. And it tends to be pretty comfortable position for the patient. And then, like I said, for a lot of the maneuvers, you're going to want to have the elbow in at least 20 or 40 degrees extension from the 90 degrees, because if it's at a 90 degrees, it's going to have a little bit too much stress and tension on the capsule, on the bursa. You might miss some fluid. So having it relaxed as much as possible is helpful. There's this additional view that you can use where the patient places their hand on the bed with the wrist in extension. And it's great for the examiner because all of the posterior structures are here really easy to access. You can get the medial and the lateral structures as well. Can be a more uncomfortable position, especially if the patient has any wrist pathology, but it can be helpful for evaluation as well. All right, so let's dive right into our protocol. So first, we're going to look at the olecranon. We're going to look, as always, in long axis and in short axis. And so here we have, I have a model to kind of give us an idea, because the patient in this case has hardware. It's going to obstruct some of the things. So I wanted to give you kind of a normal to look at as well. So you can see as we're looking down, this is in long axis of the olecranon here. Here's the skin. We want a lot of gel and not much pressure. So you could even see I had quite a bit of space between the transducer and the skin, because if there's any amount of pressure as you're pushing down on the bursa, you might displace the fluid and not be able to see a true bursitis. So very little pressure. You can see there's a lot of side artifact as I'm scrolling through here. And you want to go all the way down around the triceps, around the olecranon, looking for any amount of bursal fluid. And then this is looking at the same structure in short axis. So here's the olecranon in short axis. You have the skin and soft tissue on top, and here's the potential space for the bursa. And it's a little tricky going around the edge of the olecranon, but you want to, again, try to put as little pressure as possible. And as we're going around, you're going to see the triceps tendon, these normal slips. So don't get confused. It's not a tendon tear. Could be, but this is the normal appearance of triceps tendon to have these different slips in it. So just keep that in mind when looking at the triceps. Okay, so here's our case. So our patient, as we're sliding along his olecranon in long axis, you can see the first thing that comes to my mind is looking at the olecranon. You can see the hardware, the plate. And I really like this case because we can see the difference on ultrasound from metal compared to bone. So here's the bony contour of the olecranon versus the metal. It's a lot more clean and crisp, a lot more hyperechoic, lots of reverberation artifact with metal compared to the bone of the olecranon. You can actually see the screws really well. And what's really powerful with ultrasound is you can see right up next to where the metal is. So you can see in this image here, he does still have a little bit of fluid in his bursa here, right next to the tip of his olecranon here. So still just a little bit of bursal fluid, not a lot. And again, it's not tender, it's not red or warm. So just a small amount of fluid left. You can see the screws really well. And what's really helpful is you can see the soft tissues as they abut the plate and the screws to see if there's any kind of rubbing or any injury to the tendons that might be next to the plate. So here we're looking in short axis. And again, we can see the metal plate. You can see the olecranon process and through here. And so kind of looking at the olecranon and the bursa here, our first part of the report is going to say that there's the olecranon plate is in position. No screws are identified out of alignment. No deformity of that olecranon plate. The bony prominences are mostly obstructed, and there's a small bursal fluid present on the proximal olecranon, easily displaced with light pressure and no internal septations. So if there are internal septations, there's this thing called the swirl sign. So if you press on the bursa and there's swirling going on inside, that would be a little bit more concerned about there still maybe being an infectious process if there's particulate matters inside or septations. But yeah, just a slight amount of fluid left. All right, so moving on from the olecranon, then we're going to go into the posterior joint recess. And so again, we're going to look in long axis and in short. So looking at our model, we're going to look at the tip of the olecranon here, and then the trochlea and the olecranon fossa. There's a fat pad that is intra-articular, so it's inside the articulation, but it's extrasynovial. So any kind of joint effusion is going to track here between the bones, and here's the black hyaline cartilage. It's going to track between them back behind the fat pad. So on X-ray, you see the fat pad sign. You'll see that on ultrasound too. If there's any fluid, the fat pad is going to be superficially displaced by the fluid, or if there's a foreign body here. And so looking at this in short axis, I'm going to see the triceps tendon on top and short axis here coming up over the olecranon. We'll see the triceps tendon, and then the tendon is going to give way to the muscle belly. And there's the posterior joint recess. We'll travel up the arm, the humerus here with the triceps. And this is an excellent view to do dynamic scanning in. So it's a little tricky to do, but you can have your patient slowly flex and extend the elbow, and you can watch for any fluid that's tracking down behind into this olecranon fossa behind the fat pad. Look for any foreign bodies as your patient is flexing and extending the elbow. All right, so here's our patient. So here's the olecranon process, trochlea, and the olecranon fossa. Here is the fat pad, triceps on top, and no fluid in the posterior joint space. Do have this vessel that goes up into the triceps muscle here. And then on short axis, we can see a little bit of a tear in the triceps tendon, a partial tendon tear, right about here with a calcification inside of that tear. And then there's the vessel there at the end. And here's just a different long axis view. Triceps tendon, here's that more proximal tear. Small partial tear, doesn't go through the full thickness, has a calcification within. So likely an older tear, but as I talked to the patient, it could be related to if he had fallen on it and caused the initial septic bursitis. There could have been injury more recently too. You can have acute on chronic injuries as well. He could have had an old tear that calcified, and then he tore in that same area more recently. And then you can see here a little bit more proximally the vascularity. So part of the report here, there's hypoechoic thickening and disruption of the triceps tendon with a partial tear visualized in the distal triceps. Mild calcific tendinopathy, the distal triceps tendon, those white hyperechoic calcifications in the tendon. Small osteophytes in the olecranon process. So if you look closely here, and this is likely related to his old fracture and injury, so post-traumatic arthritis, he has these little osteophytes, kind of roughness of the olecranon. Another giveaway is if you look at the hyaline cartilage here, there's this faint white line, and what that tells you is there's could be a couple things. If it's a thicker white line, it might be a sign of gout. So gout can lay down crystals on top of hyaline cartilage and give a similar appearance. But usually what this means is that there's fluid, and it creates posterior acoustic enhancement. So just a little bit of joint fluid tracking out behind posteriorly into the joint can cause there to be an acoustic enhancement here on the cartilage, which causes this double contour line. So you'll see this in other places in the body too, where there's hyaline cartilage. If there's an effusion or joint fluid, it'll cause this double contour line. So he's got some mild arthritic changes, but no large posterior joint effusion, just a trace amount of fluid in that posterior joint, which would be physiologic. So then because of the tendinopathy, the partial tear, we want to evaluate with color Doppler. And so you can see, I always turn the Doppler up pretty high. So I had color Doppler on my machine at this time. Power Doppler works really well too at getting those small low flow tenosynovitis and neovascularization. But I have to turn the color gain up pretty high to get the low flow. And you can see a few different areas where there's some inflammation and then also some small blood vessels through here, and then that larger one at the end. So adding on to the report, we'd say there's increased Doppler flow of the triceps tendon on the Doppler demonstrating tendinitis, as well as neovascularization, so those small linear blood vessels in the triceps tendon. Okay, and then if you would like, you can go further up the shaft if there's any concern about injury farther up the humerus. You can look in long and in short axis. And we can look for the radial nerve and the spiral groove. You can watch the triceps muscle bellies. And here's the medial triceps muscle coming out here as well. And you can follow the different branches of the radial nerve down distally, and the triceps tendon as it forms here posteriorly as well. And so I did do just a quick sweep going up the humerus because of his posterior elbow pain to see if there was any irregularity of the contour of the humerus, if there were any focal swellings of any of the distal radial nerve branches, and everything looked normal. So normal contour of the posterior humerus, normal course of superficial radial nerve branches visualized with no focal entrapment or thickening. Now, if there's any kind of snapping of the elbow, you can, of course, look at the ulnar nerve, also look at the medial triceps. So this is our model again. So this is looking at the posterior medial aspect of the elbow. You have the medial epicondyle over here and the ulnar nerve sitting right next to it. And what you would do again is that dynamic flexion and extension of the nerve or of the elbow to watch and see if the ulnar nerve will cross over the medial epicondyle. And you have the medial triceps here as well that with full flexion can sometimes push itself or the ulnar nerve over the medial epicondyle and cause that snapping, which this model did not have. So normal course of the ulnar nerve and cubital tunnel with no entrapment. You can look further down into the arcade of Struthers and Osborne's ligament, looking at any kind of impingement signs of the ulnar nerve as well. I'm a family doctor as well. I take care of kids and like to make sure in any presentation that we're considering pediatric patients, their elbows are going to look a little different. So our patient's not a pediatric case, but I did want to have a couple slides since we're talking about the posterior elbow about our pediatric patients. So pediatric patients are going to have growth plates, and there's a really nice mnemonic for the elbow looking at the different secondary ossification centers. And these are kind of rough, but a quick and easy way to remember is it's about with odd numbers. So around age 1 is when the capitellum starts to ossify, and then age 3 for the radial head, and so on in the elbow. So it's a really nice mnemonic cryo to be able to remember which ossification centers. And so based on that, when you are looking at kids, so this is kind of a comparison of, this is my 2-year-old, my 4-year-old, my 8-year-old, looking at, so that I have permission to be able to show them, but looking at the posterior elbow. And so this is going to be the humerus and the Olecranon fossa. And here is all of the cartilage. And the 2-year-old, you're starting to get a couple of secondary ossification centers, but quite a bit of cartilage. Can look like an effusion. So especially in our pediatric patients, having that dynamic evaluation can help see, is that black anechoic structure that you're looking at, is that just the cartilage, or is there actually fluid that's tracking in and above the cartilage as well? It can be really helpful for diagnosing like distal humeral fractures, radial head fractures, those kinds of things, looking for intra-articular fluid. So 2-year-old, 4-year-old, 8-year-old, they got a little bit off center, but starting to see a lot more ossification. And then here's comparing to the adult. All right, so here is our report. It's a lot of words. That's why I tried to break it up for each section. But doing the complete posterior elbow ultrasound. And I think we've shared on this platform before, but as far as billing and coding goes, you can do limited ultrasounds, which is looking at just a couple of structures, taking just 1 or 2 pictures, and then doing a complete ultrasound. So you can do a complete ultrasound of one section of the elbow. I know for shoulder, whenever I teach shoulder, I tend to teach a lot of different structures all at once to do a complete shoulder ultrasound. But really, if you focus on just the posterior elbow and you do a complete scan looking at all of the bones, muscles, tendons, arteries, and nerves in that posterior region, then you're able to go ahead and bill for a complete posterior joint ultrasound. So our patient had right elbow pain in the mass. We used a linear array 10 to 5 megahertz ultrasound probe, correlated it with X-ray. I didn't have a CT scan at the time. And so here's just kind of walking through again what we had. So the Olecranon plate, I want to comment on the Olecranon process, the bony structures, comment on the bursa, the triceps tendon, posterior joint space, the humerus, radial nerve, ulnar nerve, and the cubital tunnel. And so as we went through, and then make sure and write an impression, which will include the mild Olecranon bursitis, tendinopathy of the distal triceps tendon with that partial tear and neovascularization, and mild arthritic changes of the humeral olecranon joint. Also for billing, you do need to save your images and store them. And so you'd want to save an image of each of those sections, and then store them either in your machine. Hopefully, if you have a PACS system or a cloud, you can store it there. And try to make sure and get labels on each of the pictures if you can. Makes it a lot easier when going back and reviewing images to have a label for each of the structures that you're looking at, so you can quickly know exactly what you're viewing and what the findings are. Just another shout out, a lot of work has been done for compiling these ultrasound scanning protocols. So you can go to the AMSSM website, and they're free, even if you don't have membership, which I highly recommend membership because the AMSSM is awesome. But if you're not a member, you can still have access to these ultrasound scanning protocols for free. So you can go to the website and navigate to the sports ultrasound page and look up the sports ultrasound protocols that are fantastic for many different joints, not just the posterior elbow. All right, and that's the end of my case. I think I have a few minutes here for questions if we have any. So thank you so much for your time. My email's there. If you want to reach out, feel free to contact me.
All right. Thank you so much, James, for that presentation, kind of going over a lot of different pathology for the posterior elbow, but obviously focusing on the Olecranon bursitis. I think just kind of a couple points that I would kind of make from the presentation. Definitely follow a very similar protocol. The one thing you had kind of highlighted, I think, is some of the scanning techniques for this area. A lot of the time, you know, these can obviously, the Olecranon bursitis can appear very clinically, you know, obvious, but sometimes they can still be a challenge to scan. And so really the two keys here that you had highlighted is, number one, you have to use a gel standoff technique. So heaping up a ton of gel at that area, just because, as you had mentioned, if you only have a mild amount of fluid, sometimes it can be very easily compressible. And also then you won't be able to kind of fully evaluate all the characteristics of the fluid. The other point as well too then is, yeah, I completely agree having the elbow and extension for these evaluations. Just because if you have any type of compression when you're going into flexion, sometimes even a small amount of bursal distension then can kind of be compressed in those scenarios. So definitely agree, having the elbow and extension, for evaluating these. I think on the kind of the differential, kind of the one of the main things to evaluate concurrently with this that ultrasound can be helpful for is going to be those joint effusions, as you had highlighted from the posterior elbow joint. Because really, when you have someone that's coming in with posterior elbow swelling, kind of the highest on the differential is either going to be clearly this olecranon bursitis, or is that fluid coming from the underlying joint. And this is where ultrasound can kind of easily, evaluate it. And as you had mentioned, if you have any fluid that's coming from that posterior elbow joint, it's going to be then flowing over into that olecranon fossa. The other thing I think really kind of to highlight with the bursitis, as we had mentioned, these usually are very clinically obvious, but there can be a lot of variation in the actual pathology of olecranon bursitis. And so really the kind of way that I think about these is whether it's going to be simple or complex fluid within that bursa. And then obviously the more complex fluid can be indicated of more of like an inflammatory process or even an infection and process. And so really for those, the characteristics that you're looking at is going to be the fluid itself. So if you just have purely anechoic fluid in that area, then you're going to be just thinking about simple fluid. If the fluid becomes a lot more, I think, hyperechoic, at that point, you think it could either be traumatic or even obviously in some cases then inflammatory. Usually for the inflammatory cases, you can also start to have some internal debris. And the other is going to be looking for secondary signs along the bone. And typically those are going to be erosions. And so really the two most common inflammatory, causes for olecranon bursitis would be either gout, or the rheumatoid arthritis. And so then that's where I think this can be really helpful to kind of differentiate the actual underlying cause for the bursitis, which obviously you can then highlight in the report. One thing you had kind of mentioned on some of your ultrasound images is obviously taking a look at the contour sign and trying to delineate whether this is a double contour sign coming from gout or versus just like an interface sign, which is coming from the joint fluid itself. One thing that was brought up to me by my rheumatology colleagues that really helped with this is knowing that the double contour sign, if it truly is gout, if you move that joint, so if you move then the posterior elbow, that double contour sign is not going to change. So the deposition has already occurred on that hyaline cartilage. Whereas if you have an interface sign, that fluid within the elbow joint is going to change, and so then the interface sign can actually dissipate, and you may not see that. And so then that's going to be another way you can kind of help to evaluate of whether this is truly an inflammatory process or not. So those are just kind of some of the additional points and kind of comments that I would make for this. But just a really great case, I think, demonstrating as well too that just even if patients have had previous trauma, hardware, ultrasound is really great utility in these cases, just because there's no contraindications with that hardware, even if it's present.
Yeah, thank you. And one of the things I wanted to mention, I forgot to mention earlier, when you're looking at the bursa fluid, something that can be helpful is by adjusting the gain up and down. Because if you adjust the gain up, you might be able to see some more either septations or debris inside of the fluid. And so that can also help distinguishing between, is this just serous anechoic fluid from like a traumatic bursitis? Is there blood and a hematoma? Hematomas will sometimes have a more brighter appearance than the dark anechoic fluid. And then like you mentioned with gout or rheumatism, you can get tophi there as well. And so you don't want to be imaging an olecranon bursa and think, oh, this is just fluid, and then try to aspirate or remove the fluid and then just actually be tophaceous material and there not be anything to aspirate. So make sure that you turn the gain up and down, apply pressure. If there's fluid inside the bursa, pressure is going to help the fluid to swirl around, so you have like a swirl sign if it's actually fluid, whereas if it's tophaceous material, it's not going to swirl, it's not going to move much when you're putting pressure on the bursa.
Yeah, exactly. And along with that pressure, I mean, it can also help to differentiate synovial hypertrophy versus whether this is actually true, free fluid, at that area. And as you had alluded to, kind of a
Absolutely.
little bit outside the scope of this talk, but I mean, honestly, a lot of the time, what I'm using these diagnostic scans for is, as we had mentioned once again, a lot of the time this is very, clinically obvious that they have olecranon bursitis. But then once again, you're just trying to figure out, all right, is this just, going to be a simple bursitis versus once again, one of those, inflammatory infectious. The other added benefit for the ultrasound is, as you had mentioned, is potentially if you're going to need to aspirate this. Obviously, if it's going to be simple fluid, you can usually easily aspirate those. Whereas if it's going to be something that's going to be more traumatic or inflammatory, those may be a little bit more difficult to aspirate, and so starting to get an idea of that before you just already discuss treatment options for the patients, because sometimes, especially for those hematomas, if it's been more of a chronic situation, those may be very difficult and less amenable to doing an aspiration. So at least then being able to kind of have that discussion with the patient following the diagnostic scan, I've found very helpful. All right. Well, if there aren't any other questions that I can kind of see within the chat or anyone else on the talk right now, so that will conclude today's presentation. So once again, thank you so much, Dr. Wilcox, and we'll go ahead and plan for another presentation in 2 weeks. And for that, we're going to be going over a pediatric forearm fracture.
Thank you so much for having me.